So let's go back to the case. We have a patient with unresectable stage 3B or stage 3 squamous cell. And maybe, Greg, you want to just talk about, first of all, just pathology input here. Squamous cell patients, I forgot to mention this patient was tested for PD-L1. It was 10%. Maybe talk about PD-L1 testing, whether or not to do genomic profile in these patients.
So one thing I want to just touch on first is that, pathologists in general always want as much tissue as possible. But in this era of molecular medicine and molecular testing, it's certainly becoming even more important that we get adequate tissue. So especially on these smaller EBA samples and things like that, we really need to make sure that we have adequate tissue to perform all the downstream molecular analysis. And another consideration potentially, with this patient, with these smaller biopsies is, there's squamous on the part that was biopsied, but whether or not this could be an adenosquamous lung carcinoma. And, the patient doesn't really fit the profile in being, an older patient, smoker. So, generally people would not perform kind of like the reflex molecular, NGS-based testing, looking for like EGFR, ALK, and ROS, and those type of things. In terms of PD-L1, testing, obviously, it's a very hot topic, and I think there's a real need for standardization, across the field. Initially there was a lot of different antibodies with different scoring metrics, and so I think across the field people are starting to kind of standardize what antibodies are used with what specific drugs, and as well as what specific scoring system is used based on particularly the cancer type, and then also whether it's a primary disease versus metastatic tissue that's tested.
And do you, at Rutgers, are you reflexively testing all patients, no matter what their stage is, for PD-L1, or is this something that the physician has to order? And I'll get to kind of what the practice patterns are at MD Anderson and
we're doing for advanced non-small cell adeno, we're reflexively doing essentially a small kind of NGS panel, ALK, ROS, and then PD-L1. For other cancers, it's really by physician request.
Okay.
Yeah, so we actually don't have reflexive testing, so we have to order. So in general, for research purposes, for early stage, we do test, because we have the molecular profiling trials open. But I think it's important, one of the biggest questions I get for stage 3, and I'm sure you guys do as well, is what does PD-L1 mean? Yeah. And should I be doing this in stage 3 in light of the Pacific trial data? And what I tell them is that the Pacific study looked at PD-L1. The benefit was across the board for all patients, the PFS benefit, because we don't have OS yet.
This wasn't restricted to a PD-L1 positive.
Exactly.
Yep.
So in my opinion, regardless of PD-L1, I think that all patients should be receiving durvalumab as for a year after concurrent chemoradiation.